Hello, everybody. Welcome. We got a couple more minutes and we'll begin, but try and be right on time. For those of you who want to get CME credit, you can begin to read through this. We'll talk about it in a minute. Okay, let's begin. So first, my name is I'm pediatrician and the founding director of McPap, and I'm coordinating the conversation today because Barry Servet, our medical director, is on vacation. And I'd like to welcome you all. This is our usual McPap clinical conversation that takes place on the fourth Tuesday of each month. Today's topic is identification and management of pediatric anxiety disorders in primary care. And next month, Dr. Sarah Palmer from UMass will be talking about treatment of pediatric depression. So in general, we sort of like to go back and forth between the common things and then other things, other topics that are more topical. So CME is offered, and the screen shows you how to text the code, which is SOHWEX, to start the process to get your credit. The session will be continued to be is recorded and available on the McPap website, www.mcpap.com. We also will publish the slides, and our presenter will be open to occasionally stopping for questions if you have one that makes sense. Otherwise, we'll save them to the end. Please type your question into the question box. And following the presentation, you'll get a brief survey. We appreciate your feedback and help us improve the future presentations. So today, it's my pleasure to introduce Dr. D. Shaligram, who is a child and adolescent psychiatrist at Boston Children's Hospital. She is an attending psychiatrist in the outpatient psychiatry service and affiliate faculty of global health at the hospital. She's co-director of the Boston Children's Hospital, Massachusetts Child Psychiatry Access Program, and also the International Psychiatry Observation Program. Her areas of interest include access to care, education, and social justice. She is a member of the Harvard Medical School Faculty Development Council on Inclusion and Anti-Racism, ACAP's Climate Change Committee, and the co-chair of the Diversity and Culture Committee at ACAP. Dee serves on the board of the New England Council on Child and Adolescent Psychiatry and the Family Process Institute. She is also a fellow of the American Psychiatric Association and a distinguished fellow of ACAP. She enjoys teaching, psychopharmacology, scholarly writing, and outpatient consultation, liaison psychiatry. So Dee, why don't you bring up your slides and let's get going. And again, if people have questions, they can put them in the question box.
Thanks for your kind introduction, John. Pulling up my slides as we speak. It's a pleasure to be with you all today to talk about the identification and management of pediatric anxiety disorders in primary care. I have no disclosures. Our learning objectives today will be to consider an overview with diagnostic considerations and differential diagnosis of anxiety, how to measure anxiety in primary care settings, then move on to treatment options, which include medication and therapy, and finally, when do we involve specialty care? I love questions. I feel like we learn best when we ask questions. So please do drop your questions as they arise in the chat box. I will plan to get them at the end of the talk. So anxiety is normative at certain ages and developmental stages. For instance, between the ages of 6 to 12 months, infants experience stranger anxiety. At that point, they know familiar from unfamiliar faces, and they may experience distress and anxiety when they are faced with the unfamiliar. Similarly, separation anxiety is normative between the ages of 8 to 14 months. And this occurs when children have formed strong bonds with primary caregivers, and in the absence of these caregivers, they experience separation anxiety. Now, we expect that as children grow and gain independence, they grow out of these anxieties. But if these anxieties persist and intensify beyond the normal developmental stage, that signals a problem. So anxiety disorders are high prevalence, early onset conditions.
Dee, I'm sorry. Did you mean to advance slides or?
Oh, yes, I believe I have advanced the slide from my end. Let me see. Yes.
There we go.
So, okay, thank you. So these are the learning objectives that I went over. And then I am on this particular slide. Thanks for that alert, John. So pediatric anxiety disorders are high prevalence, early onset conditions, and they are the most common pediatric mental health condition. In fact, if you look at a lifetime, 30% of people develop some form of an anxiety disorder transiently during their lifetime. Going on to the early developmental stages and how anxiety shows up. Anxiety disorders can show up in toddlerhood as behavioral inhibition. Jerome Kagan characterized temperamentally slow to warm up children as behaviorally inhibited when there was withdrawal in the face of novelty, when they interpreted neutral stimuli as potentially threatening, there was an associated clinging to an attachment figure, lack of talk, lack of smiling, or limited eye contact. Now, when children are behaviorally inhibited at these early stages, if parents accommodated this behavior, then it tends to reinforce a child's fears. And down the line, by age 5 and 6, those anxieties show up. And social anxiety has been correlated to having behavioral inhibition at an earlier stage. However, when parents gently encourage their child to step out of their comfort zone with support, children are more likely to grow out of these fears. This is just to highlight how anxiety is responsive in the early developmental stages to nurture and environmental conditions. So when does anxiety become a disorder? Anxiety is normally triggered by external stressors, and it motivates us to prepare, take precautions, and perform at a peak. It tends to resolve when the external stressor passes. Consider a child who is nervous about an upcoming test. This creates a drive to prepare ahead of time to take the test, and that's a normative experience. If this same child is unable to sleep the night before a test or freezes and goes blank during the test, despite adequate preparation, then the anxiety has become maladaptive and is a problem. So to the right of the slide, you see that problem anxiety interferes with daily life. It is the counter of normal anxiety, which is wired into our brains for adaptation and survival. Anxiety disorders are internalizing disorders, and they are a great mimic. So not only do they co-occur with ADHD, depression, and other mental health conditions, it can look like these conditions. For instance, irritability and temper outbursts that occur when a child is overwhelmed by fear can present as the fight reaction instead of the classic flight reaction that we generally associate with nervous children. This irritability can be mistaken for externalizing conditions like disruptive mood regulation disorder and internalizing conditions like pediatric depression. Further, the restlessness of anxiety can be confused with hyperactivity of ADHD. And when worry thoughts swirl through a child's head constantly, it may present as a lack of focus, spacing out, and difficulty with task completion that is suggestive of inattentive ADHD. So these are some conditions to keep in mind, and it's important to parse out whether these conditions are comorbidities or is it anxiety that is presenting like these conditions. The DSM-5 recognizes 9 types of anxiety disorders which can coexist with each other. And the common thread, the common symptoms which run across these anxiety disorders is an excessive worry that is difficult to control and out of proportion to the situation, which then results in reactivity, either withdrawal from the anxiety-provoking stimulus or behavioral outbursts and irritability, a hypervigilance or scanning of the environment for threats, anxiety-provoking stimuli, and then disturbed sleep and physical symptoms as a result of the overwhelming anxiety. And the physical symptoms can look like stomach aches in younger kids and headaches in middle childhood. Now that we've had a quick overview of anxiety disorders being early onset, high prevalent conditions, and some of the differential diagnosis, let us look at how we can measure this anxiety and diagnose and treat it. So starting off with broadband instruments like the pediatric symptom checklist, if it were to be positive for excessive worry or fear, avoidance of certain situations, or physical symptoms like headaches and stomach aches, it's our cue to go on to the narrowband anxiety-related instruments. So that's the SCARED, which is Screen for Child Anxiety-Related Emotional Disorders, and the Generalized Anxiety Disorder 7, which is pictured to the left of this slide. This SCARED is geared towards younger children, and it can go on up until age 18. It has both parent and child informant versions, and it can, determine the subtype of the anxiety disorder that is present, whether it's generalized anxiety, social anxiety, separation anxiety, panic, or school phobia. And the cutoff score for the SCARED is 25 and above. The generalized anxiety disorder 7 scale is geared towards older kids, so 12 and above. It can also be used in adults, and the cutoff score for the G87 is 10. Some important notes to keep in mind: these rating scales need to be used along with good history, as the scales by themselves offer only a part of the information, and there can be discrepancies between the different informants. For instance, the SCARED might be positive for the parent version, but not the child version, or vice versa. And you might wonder why that is. So when children are highly anxious, they may be good at masking symptoms and they may present as diligent, rule-following, model children, and parents may be completely unaware that their child is internally quaking with fear. Sometimes the converse is true, right? A child version of the scared might be insignificant, even though the child is experiencing anxiety, because with early onset anxiety, a child may have no comparison point and they may not realize that the anxiety that they are experiencing is excessive in comparison to their peers. So just a couple of points to consider when administering these rating scales. Rating scales can be helpful to establish a baseline. And as we keep treating the condition, monitoring how improvements are happening and in which items you're seeing the most improvements, and to set further treatment goals, whether it is in therapy or with medication management. So this particular slide is the anxiety care pathways for pediatric primary care. It is available on our MacPap website. And I have the first half of it here. It walks us through how to screen with a broad screen and then conduct a focused assessment. And it subdivides the anxiety symptoms as subclinical or mild anxiety, and then moderate anxiety, which correlates to the G87 of 10 to 15, and severe anxiety, which is G87 of 15 and above. So for subclinical and mild anxiety, which correlates to G87 of 5 to 10, the recommendation is guided self-management with follow-up in primary care. And we're going to talk about that in just one slide. Whereas for moderate anxiety, the first referral would be to therapy, and you can add on medications as appropriate. So combined treatment is definitely an option. Whereas with severe anxiety, combined treatment from the get-go would be important. So medication as well as therapy. The guided self-management toolkit that I'm going to be talking about is available on the Building Bridges of Understanding website. And it starts up with things children can do to empower themselves. As you can see, it begins with identifying fears and creating a hierarchy of fears based on severity. That's the fear thermometer. Then there is learning of relaxation skills, which are supposed to be incorporated into a child's daily routines, and identifying thinking traps or cognitive distortions, as we call it in cognitive behavioral therapy. And finally, facing fears or exposure, as we call it, in CBT, with the support of a trusted adult, like a parent. The Guided Self-Management Toolkit also offers guidance on what parents can do to support their child with anxiety. And that starts up with first acknowledging and validating the fear instead of dismissing it or ignoring it. And then allowing for mastery by rewarding brave choices, modeling positive coping, and managing a parent's own distress, internal distress at seeing their child suffering. We're now moving on to the second half of the anxiety care pathway. Notice that it focuses on two selective serotonin reuptake inhibitors, fluoxetine and sertraline. And the green rectangle talks about how to start each medication and at what point we increase it to a therapeutic dose. So we're starting low and going slow with this titration. It also warns us that we need to monitor carefully for emergent suicidal ideation, agitation, and other side effects, because in the case of these medications, the side effects appear first before the therapeutic benefits. So starting up slow and going slow, starting up low and going slow might mean that we avoid those side effects or prevent or mitigate them. Also in this green box, we have mention of hydroxyzine, which can be helpful with reducing severe distress associated with anxiety. Higher levels of hydroxyzine can also be helpful with treating anxiety-related insomnia should melatonin dosed 1 hour before bedtime at the 1 to 3 milligram dose is ineffective. It's really important to utilize the hydroxyzine to tamp down the levels of anxiety from the get-go, because if the anxiety is severe, a child might not persist with the use of their mainstay medication like the SSRI, because these mainstay medications can take up to 6 to 8 weeks to fully kick in. The next segment of this slide talks about what we are going to be doing in follow-up. It walks us through follow-ups at the 1 month mark, 2 month mark, 3 month mark, how to up-titrate the medication, at what point we might consider a medication as not helpful, and what to do then. So how do we cross-taper to a different medication, right? And then if help is needed in the cross-taper process, we are available as MedPAP consultants to walk a primary care provider through that process. And typically after 12 months or so of being symptom-free, medications can be tapered and stopped. And that is also explained. So 25% decreases in dose every 2 to 4 weeks at a time of low stress for the child. So that's in a nutshell. And this one pager can be really helpful to have as a reference as medications are started up and adjusted. Outside of the 2 medications that were referenced in the previous slide, there is an FDA approval for pediatric anxiety for the serotonin norepinephrine reuptake inhibitor, duloxetine, and in 2023 for another SSRI, escitalopram. So given all these different options for medications, how do we choose a medication for a child? So some of the considerations to keep in mind would be the age of the child, the efficacy of the medication, the side effect profile, family history of response to medication, family preference, drug interactions, and finally dosage forms. For instance, young children may not be able to swallow pills, and choosing a medication that is available as a liquid might mean that the anxiety can be treated in a timely way. The various medication options, as well as the side effects and the timelines to response, are all described in the Parents' Medication Guide from the American Academy of Child and Adolescent Psychiatry that is pictured to the right of the slide. The language is simple and easy to follow. There are also tools for medication adherence, which can be really helpful. It also talks about therapy. So something to consider as a resource to offer families. So this is a slide that puts together all our different options for the treatment of pediatric anxiety with medication, right? So the first 4 options are the SSRIs, and 2 SNRIs are listed in the bottom 2 rows. It talks about the indications for use. It talks about some of the side effects and how to titrate the medications, the formulations in which it's available, and what the maintenance dose range would be is our last column. Please keep in mind that the higher ends of the dose range mentioned here are really for OCD. OCD used to be considered a part of the pediatric anxiety disorders in the DSM-4 and before. So a couple of points that I wanted to make on this slide. Option number 2 here is fluoxamine. It's FDA approved for treatment of OCD. At lower doses, fluoxamine might present an alternative to fluoxetine, sertraline, and escitalopram for the treatment of pediatric anxiety and depression. And if the other medications have been tried and found ineffective, or if for some reason there is a contraindication for one of those medications, it's possible to get a phone consult to consider one of these other medications. So fluoxamine is one. The other medication that is mentioned on this slide that we don't typically talk about with pediatric anxiety in primary care is venlafaxine. Venlafaxine has had randomized controlled trials showing some efficacy in pediatric anxiety. However, in terms of tolerability, so missed doses, it can have withdrawal side effects, which can be disabling. So it is not our first go-to, but if there is a family history of good response and it's an older child that we are treating, might present an additional tool.
We had a question that maybe you could, just as you go through the medications, just to keep in mind, or how do you judge the use of therapy and along with the medicines?
That's a great question. How do we, consider use of therapy with medication? So I'm gonna divvy it up as real world concerns and theoretical what's good. Some of the real world concerns are there can be a wait list to get into therapy, right? If we are treating a kiddo with moderate anxiety, typically we start off with therapy and then add medication if the therapist feels you're not making enough progress in therapy. And then with severe anxiety, although I said combined treatment is the way to go, it may make sense to start off the medication first because medications, when they work well, can actually kick in by week 3 or so. And that can tamp down the levels of anxiety such that a child is able to engage in therapy. A child with severe anxiety, especially, is able to engage in therapy, learn the skills, and implement it. So with therapy skills, learning those skills and putting them into action can be a process. With starting up medications at the same time as therapy, or even in advance of therapy, if there's a wait list for therapy, it can make sense in the real world. I'm going to be talking a little bit more about therapy and the family aspects of therapy in just a few slides. So I'll get back on track with the medications and come back to this question if you have further questions about the therapy end of things. Thank you for that question. Makes me happy. So SSRIs and pediatric anxiety disorders are the first line, most commonly prescribed because of their safety, efficacy, and tolerability. SSRIs also have the fastest rate of treatment response compared to the SNRIs and a larger magnitude of treatment response compared to the SNRIs. However, with the SSRIs, we really want to underscore starting low and going slow with the dose increase, because if we don't do that, and if we don't psychoeducate our families on what to expect, they are more likely to be discontinued than the SNRIs because of side effects. And the side effects can be as mild as the gastrointestinal side effects, which are common. So taking it with food would prevent or minimize the side effects. So the side effects are nausea, acidity, and diarrhea. Or it could be the more significant side effects like activation, which can happen with both SSRIs and to a lesser extent SNRIs. And that looks like irritability, which is more so than before, impulsivity, decreased sleep, and it tends to signal that the medication is a poor fit because either it started up at too high a dose or has been increased too rapidly. And in those instances, scaling down on the medication would resolve the activation. So when side effects do show up, they tend to iron themselves out as the body gets adjusted to it in about a week or two. And the therapeutic benefits really show up down the line. So psychoeducating families about that can prevent premature stopping and discontinuing of the medication. Another big side effect that is of concern to families and might be a deterrent to families starting up a medication like an SSRI is the black box warning. My last point on this slide says treatment emergent suicidality does not differ amongst the different classes of medication used in pediatric anxiety disorders, but there's a footnote here. It does differ based on the individual medication. So I'm going to talk about that in this next slide. So we have the FDA boxed warning here. Antidepressants are associated with increased risk of suicidal thinking and or suicidal behavior in children compared with placebo, especially during the early phases of treatment. I've added in those numbers there. So 4% of children compared to 2% on placebo. And that is to give emphasis to the context and the numbers. More recent studies and larger studies have suggested that the associated risk is even lower than these. And you also want to note that these show up in the early phases of treatment. So if suicidal thinking or suicidal behavior shows up in the middle phase of treatment with no associated recent increase in the medication, it is unlikely to be because there's a medication dose adjustment that has been done. It's more likely to be coming from environmental stresses or intensification of the disorder by itself. So in terms of the individual medication differences that I referenced a second earlier, sertraline has been one of the medications that actually has lower risk of suicidal thinking and behavior compared to placebo. So lower risk compared to placebo in pediatric anxiety, as well as lower risk compared to 6 other active treatments for pediatric anxiety, including an SSRI paroxetine and 2 of the SNRIs, which I had referenced, that is duloxetine and venlafaxine. So maybe an important piece of information and might guide choice of medication when parents are nervous about starting up an SSRI or an SNRI for the treatment of anxiety. In terms of dose titration, the general rule of thumb is to increase the dose of the medication every 4 weeks. And the idea is that the body then has time to adjust to that dose. Remember, it takes 2 weeks, 1 to 2 weeks for side effects that are incited by a medication to settle. And by week 3 or week 4, we start seeing early signs of improvement. So by week 4, if we haven't seen signs of improvement, especially in anxiety, we might want to consider switching to a different medication. We might want to look at our diagnosis more closely to see if there is another coexisting condition that we need to address that is complicating the picture and influencing treatment response. And if 2 or more medications have been tried with no improvement or partial improvement, consultation an opinion of a specialist would be a good idea. Okay, so I've included this slide because we often get the question of using pharmacogenetic testing to choose the right medication from the get-go. And the quick points to remember and discuss with parents is that there is an FDA warning that came out in 2018 against the use of genetic tests to predict medication response in children, just because the few commercial genetic tests have had RCTs only in adults, that too small sample sizes, short duration of follow-up, lack of blinding, lack of an appropriate control group, and with conflicts of interest. And these tests provided little guidance when 2 or more medications had to be used concurrently. And that encapsulates the guidance provided by the ACAP in their 2020 policy statement, which recommends not using these medications to pick not using these tests to pick a medication. And since the 2020 policy statement came out in 2021, there was a RCT done in teens with depression, trying pharmacogenetic testing that is pictured to the right of the slide, and it came to that very same conclusion. Okay. This one pulls all the information about medication together. It is a network meta-analysis of all double-blind placebo-controlled studies of medication in pediatric anxiety, and it looks specifically at efficacy and tolerability of the medication. And this is a forest plot of treatment response. Treatment response in medication trials for children with anxiety, in this case, is defined as a 50%, a clinically significant improvement of 50% of the anxiety symptoms improving in response to the medication versus placebo, as measured by a standardized rating scale. So that is the definition of treatment response. And let me quickly orient you to this slide. We have different classes of medications that are listed. And these medications have been compared to placebo for a treatment response, and we see odds ratios here. For reference, an odds ratio explains an association between an exposure and an outcome, right? So in this case, the odds ratio depicts the association between improvement in anxiety symptoms, which is the outcome, with the exposure, which is exposure to the specific medication, whether it's an SSRI or an SNRI, compared to the odds of that same outcome, meaning anxiety symptom improvement, without that exposure. So in all these RCTs, it was placebo that these medications were compared against. And one thing to remember is the odds ratio, which is mentioned on the right side of the slide. If it were to include span the number 1 in the credible interval, it is not considered statistically significant. So the first option, SSRIs, in parentheses, we see ranges from 3.1 to 7.5, which does not include the number 1. So the treatment response to an SSRI is statistically significant. Similarly, with an SNRI, which is the second option on that slide. The third option, the TCAs, or the tricyclic antidepressants, within parentheses, you see the numbers go from 0.8 to 4.9. Right? So it includes the number 1, not statistically significant in treatment response for anxiety. Similarly, the benzodiazepines, which are next. So please note, benzodiazepines are not useful or not well tolerated, or both, in pediatric anxiety for outpatient management. And interestingly, the alpha-2 agonist, and this particular trial, you see within brackets 1. So this particular randomized controlled trial was done with the guanfacine extended release. And on the right side of the slide, you see the credible interval does not include the number 1. So it was statistically significant for improvement of pediatric anxiety symptoms, and maybe an additional tool that we don't immediately think of when we look at treating pediatric anxiety. So in a nutshell, they found SSRIs, SNRIs, and the alpha-2 agonists are, efficacious and tolerable in the treatment of pediatric anxiety. So this brings us back to cognitive behavioral skills and how they might add on to medication management. These are the 4 principles of cognitive behavioral therapy, which is the gold standard for therapy treatment of pediatric anxiety. And it consists of identifying an anxiety-inducing situation or situations, and then creating a hierarchy based on severity, learning relaxation techniques and implementing them in situations where a child is in an anxiety-provoking condition. And finally, the pieces where the cognitive behavioral therapist can be really helpful with is identifying the cognitive distortions or the thinking traps and challenging those cognitive distortions. And finally, facing those fears or exposure response prevention, facing those fears in a controlled and safe way. So that is something, those skills are something a child can carry with them wherever they go. And a child can put into practice when they are suddenly in an unpredictable, anxiety-provoking situation. The cognitive behavioral skills have an important role to play in addition to medication, right? Because medications can, when they're on board, create conditions that diminish anxiety, the anxiety experience for a child. And once those symptoms are resolved and we taper and stop the medication, we still have a child that is prone to anxiety. So if the child without the anxiety-prone child is without medications but carries their cognitive behavioral skills coping with them, they can employ it at will. And it is suggested that CBT is intensified as we are tapering and stopping medications. Just because that it's a booster. CBT is typically time limited, 3 to 6 months long at the most. And as I reviewed before, typically we continue medications for at least 1 year of a symptom-free period before it's tapered and stopped. So by the end of the 1 year, the original CBT course has been completed. And to ensure success of the tapering and stopping of medications, putting on booster doses of CBT at that stage can be really helpful. The additional point I wanted to make here is earlier this year, Jeff Strawn had published a study on paternal anxiety and its impact on children. And the study showed that, so previously studies have shown correlation with maternal anxiety, but the paternal anxiety is also influencing a child's anxiety symptoms and the development of anxiety in children was new, and it underscored the importance of considering parents' mental health when you are assessing a child at risk for anxiety disorders. And it also talked about how there's a behavioral transmission of anxiety from parents to children. So if children observe their parents becoming anxious and dealing poorly with it, they may learn those maladaptive coping styles. And that is where it can be really helpful to include parents in the therapy interventions for the child so they understand the child's experience and what their own behavior, the parents' own behaviors, how it might be impacting their children. And by including the parent and the child in the therapeutic intervention, parents also gain mastery to a certain extent of their own fears, or get motivation to get their own help. So that is the value of including parents in the treatment process. And finally, when do we consult psychiatry? Obviously, when there is acuity involved, either in the form of suicide ideation, intent, recent suicide attempt, definitely involve the emergency room or a mobile crisis unit, so that a specialist can assess the child and propose treatment. If there is complexity, either in the form of a family history of bipolar disorder, or there are adverse reactions to medications or unusual reactions to medications, which is not uncommon in children with developmental disorders, or if there is a suspected comorbidity, whether it's psychosis or substance use. And finally, if despite adequate medication trial, so an adequate medication trial would be medications indicated for anxiety at a therapeutic dose range for a period of 6 to 8 weeks. To quickly recap, side effects show up in the first 1 to 2 weeks and also resolve. Then by 3 to 4 weeks, we have the beginnings of a treatment response, and that treatment response increases exponentially over the next few weeks. And we see the maximum benefits of that particular dose at the 6 to 8 week mark. So if you've had adequate trials of a medication, 1 or 2, and we are still seeing partial improvement or lack of improvement despite appropriate titration of the medication, then too, it would be important to seek specialty care input. So to summarize, anxiety disorders are early onset, high prevalence conditions, and they are more likely to be identified in primary care. It is important to remember that they may present as irritability in young children. So as opposed to the usual flight reaction that we might see in children, if you are seeing the fight reaction, still do consider anxiety in your differential diagnosis. And of course, the freeze reaction is something we also consider as a part and parcel of anxiety. And the mainstay of treatment is really a combination of cognitive behavioral therapy with the serotonin reuptake inhibitors, whether it's the SSRIs or the SNRIs. Some useful resources that I've included on my slide here. I start off with a statewide behavioral health helpline. It is available regardless of insurance. The number is right there on the slide. You can call or text 24/7. Families can access help that way. And the resources available include a mobile crisis unit, options for getting a list of community therapists or prescribers, neuropsych evaluations, and it's just a helpful number for families to have if they, are ever in need of, say, a partial hospital program or a higher level of care. The next 2 resources are geared towards families. The Child Mind Institute has videos as well as blog posts on what anxiety in children can look like and what to do when faced with an anxious child. They have steps similar to the guided self-management toolkit that I had showed a few slides earlier. The ACAP facts for families normalizes the anxiety experience, and the benefits of seeking treatment for anxiety early on is also outlined here, because anxiety, if we intervene early, we are changing the trajectory of a child's life. Development of comorbid disorders down the line might be averted. There's often, anxiety often morphs into depression down the line if it is untreated or undertreated. Substance abuse is a concern in the teen years if anxiety is not identified and treated early. So those are all things that are avoidable if we intervene early, and that is laid out beautifully in the facts for families. And finally, the Anxiety Disorders Resource Center that came out last year on the ACAP website offers, guidance for treatment providers. The next slide has my references. The MACPAP website, in addition to the treatment care pathways, I want to mention also has the clinical pearls, which are really helpful. It is subdivided into sections, and how to assess symptoms, how to generate differential diagnosis, how to treat, and the various treatment scenarios that can come up. And I would encourage you to take a look at it at your leisure. And that brings me to the end of my presentation. Thank you so much for your kind attention. I'm happy to take questions should you have any.
Thank you very much. We do have a few questions, so let me shoot them off to you.
Excellent.
In terms of, do you have any recommendations around the timing of dosing? Morning, afternoon, bedtime?
Excellent. Okay. All right. So yes, thank you so much for asking that question. I'm going to rewind to my slide that has a summary of, all the different agents. Most of these medications have to be dosed with, or all of these medications have to be dosed with food to minimize side effects. And the pharmacological profile often determines when it has to be dosed. Fluoxetine, which is right up there on that slide, is energizing in its feel. And because of that, is ideally dosed in the morning after breakfast. All the other medications can be dosed at night, because especially at higher doses, these medications can cause some tiredness, which can help deepen sleep. It does not affect energy levels during the day when it is dosed at night. I will also say that starting up, it may be fine to do low dose of an SSRI or an SNRI in the morning, even those that have the potential to cause tiredness, just because when you dose the medication in the morning after breakfast, you have all the rest of the waking hours to examine what might be the side effects the child is experiencing. And typically at lower doses, you don't see tiredness as a side effect. So once you know the medication is well tolerated and you keep up titrating it, at a certain point, tiredness is going to be a side effect or is already a side effect. At that point, it's fine to move it up to bedtime. So simple answer, fluoxetine, most commonly given after breakfast. And as we keep titrating the dose upwards, it stays there after breakfast. Whereas the other medications, you can start in the morning just to observe the child for adverse effects. And some children are fine dosing even higher doses of the sertraline in the morning, but some others might experience tiredness at the, say, 50 milligram dose, say, and it has to be moved up to the bedtime. So that is to answer your question about when to dose the medication.
Great. Another question is, do you recommend any lab tests?
Good question. So we don't routinely do lab tests. for starting up these medications, but there are always exceptions. So one of the side effects of serotonin-based medications is that it can increase bleeding tendencies, right? Because of their antiplatelet side effects. If there is a pre-existing bleeding tendency in a child, it might be helpful to get the baseline. And one other side effect to keep in mind with serotonin-based medications is QT prolongation. So fluoxetine, escitalopram, and citalopram have a tendency towards QT prolongation. So if you know that there's a family history of QT prolongation, then it might be a good idea to get a baseline EKG in a child, preferably try something different that doesn't have that risk profile. But if it is necessary to try one of these medications to get a baseline EKG and to monitor. SSRIs and SNRIs are considered safe with the long-term use. There are some children and adults that need it for a prolonged period of time. And this is more for adults rather than children. There has been some association with hyponatremia, so lower sodium levels with long-term use. It's usually not a concern in the pediatric population, but just something to be aware of. So that is in terms of lab tests that might be needed.
So I just want to remind everybody, because all these any of these little quirks, call McPap. We're here to help you. So if something doesn't seem to be going the way it ought to go, you can always call us, especially in order to find out whether you do need a specialty referral, because that's not going to happen quickly overnight in most cases. So we can often do something to help you along that process. In terms of, would you talk a little bit more about how long you would treat? So even if the question here is even when the anxiety has become manageable but is still there, would you feel comfortable continuing?
Great question. It often comes up in clinical practice. So, soon after a child starts feeling better, say a month or so, at the follow-up, families will often ask, things have been really good for the past month. Do we really need it anymore? And the answer is, on this slide, we talk about how we think through the treatment stages. The second box right at the bottom of the slide says remain at the current dose if you're seeing improvements, right? And you continue it on for about 12 months or so. The reason being the maintenance treatment can help reset the brain circuitry and the neurotransmitter levels. In the beginning, in the first 1 month or first few months of seeing those anxiety symptom improvements, those anxiety symptoms are resolved because you have that medication on board, because the child is in therapy. But if you were to pull out the medications prematurely, then the anxiety symptoms come right back, because the brain hasn't had a chance to heal and reset such that normal levels of serotonin and norepinephrine are produced. And by continuing the same dose of the medication, or maintenance dose as we call it, for a period of about a year, then we are giving the brain a chance to reset. And we typically taper and stop medications on a trial basis at a time of least stress, say summer vacation. And the tapering is done with a reduction of 25% every few weeks, usually a month, because if there is a flare-up of anxiety symptoms during that phase, we can always go back to the previous dose so that it does not spiral downward and become another episode of severe anxiety. I hope that makes sense.
Great, thank you. I think that's all the questions we have in the chat, but please feel free to take yourself off mute if you have a question, or you can type it in the chat. Okay, it's almost 1:15, so I think we'll honor everybody's time, and we really thank you, Dee, for this wonderful presentation. Reminder that it will be available on the MCPAP website, both the slides and the presentation if you want to listen to it or want someone else to listen to it. And if you have any questions, you can email us at mcpap@carillon.com, or go on the website and email us. And remember, you're going to get a survey, so we really appreciate you completing that. So with that, everyone have a great day. Thank you.
Thanks, everyone.